We have reordered the afternoon, and we're going to have a guided discussion at this point. So I'd like to have Dr. Gupta and Dr. Shapira come up, and they will guide the panel that was to discuss the various areas at the tabletop. So if you two would come up, and then we have Dr. Blackman, Talim Mohammed, Dr. Martello, Dr. October Eden, Dr. Frazer, and we need one more chair. And Lakeya, if you would like to come to the front, and then we will have a discussion on the various areas listed.
Good afternoon, everybody. I'm Dr. Gupta. I'm Ravi Gupta from pathology. We're going to start a panel discussion, so we've just had a change of the format, and then we're going to do the whole group discussion together. And this will be a very conversational style, and if anybody has any question, please feel free to raise your hand. And even for the speakers here, if there is anything you want to add to the discussion, feel free to add to the discussion. Can everybody hear me? Okay. I just wanted to start with having the speakers introduce themselves and maybe one or two lines about what they would like to sort of facilitate, talk about today. Do you want to start?
Hi, good afternoon, everyone. Can you hear me? I'm Marilyn Frazer. I'm the CEO for the Arthur Ashe Institute for Urban Health, and I'm the co-director of the Brooklyn Health Disparity Center here at Downstate, which is a partnership between the Institute, SUNY Downstate Medical Center, and the Office of Brooklyn Borough President. So today, what I would like to talk about or discuss with you in part of a conversation is how do we engage our community in pursuing healthy behaviors, and this would be based on a lot of the work of the Institute in conducting culturally tailored interventions within the community.
So my name is Laura Martello. I am the Director of GI Research here at SUNY Downstate in the Division of Gastroenterology, and from my perspective, some of what I would like to talk about today is colon cancer screening, increasing the screening rates, as well as something that was touched upon in a few of the discussions, is actually looking at the tumors from these various cancers at the molecular level to try to better understand the impact on the higher incidence in these populations, as well as the higher mortality rates.
Hello, I am Rosalind, October Eden. I'm a visiting assistant professor at SUNY Empire State College. I am a social worker by trade, and the focus of discussion that I would like us to get involved in revolves around culture. How is the cultural piece impacting what we do and do not do regarding cancer diagnosis?
Hi everyone, my name is Lizabeth Blackman and I'm an epidemiologist by training, currently a doctoral student at Temple University. I work at Fox Chase Cancer Center in their Cancer Prevention and Control Department, and I work with Dr. Reagan, who just gave us an awesome talk, and our focus is cancer health disparities, and I'm also here to help with the discussion as far as how culture affects our screening rates in the African American community.
Hello, good afternoon, everyone. My name is Lakeya Maxwell. I am the project staff assistant at the Brooklyn Health Disparity Center, and I'm also an MPH student at Hofstra University. Today, my discussion will be focusing on the importance of social media and social networks within the health field and how we can use it to promote healthy behaviors.
Okay, thank you very much.
And I am Valerie Shapira. I am the chief of the Division of Hematology Oncology at SUNY Downstate, and obviously I'm extremely interested in how to get cancer patients to seek care and to prevent cancer in our community.
We've had a range of discussion today, starting from epidemiology to the genetic basis of of disparity in different populations. I wanted to start with, I did one of the slides that Dr. Reagan presented. She talked about cultural differences, and that between African American and Caribbean population, there is a cultural aspect that they proved by one of the studies that Caribbean people want the healthcare provider to make choices for them. I wanted to ask Dr. October Eden if you've seen that type of difference between African American and Caribbean population to have that cultural difference in decision making.
I think when you consider the differences in the cultures of people coming from the Caribbean and people who are, when I say people, I mean African Americans who are born here in the US, and Caribbean men, especially the ones born in the Caribbean and migrating, men and women, there is a cultural difference, for sure. Because when you think of the lifestyles had in the Caribbean in comparison to the lifestyles here in the US, for example, I was talking to Dr. Weiner earlier today, and I was sharing a situation whereby, and this is very personal, and it's funny, but it's not. I'm from a very large family, and there is one brother who is left back in Guyana. I'm an immigrant myself. And my sister actually said to him, meet me in Trinidad for a week vacation. It's happening right now. I'm not making this up. But the reason why she did that was because he has some health challenges. He has the means of doing the workup with the doctors and all of that. He wouldn't. It turned out that that visit to Trinidad was to get some medical assistance. On my way here, he called me and he said, you know what? There is no diabetes, there is no hypertension, there is no prostate cancer, but I have gout. And I said, okay, well, you have to follow up. And I said, because the test says that you don't have cancer doesn't mean that that's the end of all. You still have to do a colonoscopy. But I'm saying that to say, folks in the Caribbean, they are quicker to use a homemade remedy if there is a problem, as opposed to going to the doctor. And when that behavior is transported with them when they move, when they migrate, is a similar self-application to how they become assimilated in the culture here. So it makes it different and really a challenge for them to think about going to the doctor, and following through would be the next issue. So yes, there is a big difference, and it has to do with how individuals were raised. Similarly, with the African Americans born here, if their family culture is not to seek medical care and not to seek medical care timely, that would be an issue also. So there are some differences.
Dr. Frazer, did you want to talk about how you overcome these type of cultural differences just within the African American community, focusing especially on different cultures?
So I think with overcoming challenges, it's actually reaching people where they are, identifying what the different cultures may be. So at the Institute, one of the things that we do a lot of formative work to find out where people are and let them tell us what things would work for them. So in terms of prostate cancer, for instance, or when we talked about breast cancer, we conducted focus groups with a set of individuals that were both from African American descent and folks that were Afro-Caribbean. And we talked about different things, different cultural issues related to breast cancer, for instance. And what we found that one of the things people did not want to talk about is cancer. It's a big word, it's the C, the big C. I know of folks that would have a normal conversation and it would be a normal tone until they get to the word cancer, and it becomes cancer, or it becomes, that thing. And so when we did our breast cancer work, one of the things we realized that people were more comfortable talking about health. And so instead of addressing breast cancer or reducing breast cancer risk, we changed our tone and we change our language to talk about promoting breast health. And so those things are important, finding out where people are in the community, and so that they can also buy into what they're doing, and so they have ownership, and it also helps in terms of sustainability, it helps in terms of people following through with the different interventions that are developed, because the interventions are developed and they are tailored to them. And people feel ownership to those interventions that are developed and tailored to the community.
Dr. Shapiro, actually, I want to pose a question to you. You being a clinician, you see so many patients of all cultural differences. What is your experience with patients of different cultures? How do they seek advice from you? Are they suspicious? Do they trust you? And how do you build sort of these relationships?
So the Central Brooklyn population is unique. They expect me to make the decisions for them. So in other places I practice, you tell the patient, you have cancer, we're gonna do A, B, C, D for you, and with treatment A, this is the success rate. With treatment B, I cannot do that. I start doing that. That's how I start my conversation, but then I'm stopped. No, I want you to tell me what you recommend, doctor. So in a way, I have to take ownership instead of giving it to them. These are the options, you pick. No, you decide what's best. Okay, so that's one aspect. The second aspect is what Dr. Wiener said. There is some mistrust. And I think the mistrust is that so many times, probably they were let down. So they went to office or to some authority and they were let down. They were not helped. So I overcome that pretty quickly by just showing to them that I'm there for them, that I am at their service, and I'm here to serve them. So, and then it becomes very warm. The relationship warms up, and I'm kind of adopted in the family. And at that point, conversations are much, much easier.
I also wanted to add, just as a society in the United States, African Americans as a whole, we've been used as guinea pigs. Everybody in here is a health practitioner, so we've all heard about Tuskegee. So as a whole, we go into the doctor's office and we're kind of apprehensive because we don't know, are you really here to take care of me or are you really here to help me? So like I said, I work with Dr. Reagan. So for CAP 3, we've recruited a large number of African Americans or people of African descent, and it's because when we go out in the community, we look like them.
Yes.
Even with you're an immigrant yourself, so they're like, the doctor is, she's
right.
similar to me. She,
right. I have an accent, and
and they feel more comfortable. They don't feel like you're going to take advantage of them.
Right.
So they trust you, and then also as doctor, they trust you. They're looking at you that you have this information, and you're going to take care of me. You're concerned about my well-being.
Right.
So they are just like putting so much trust and faith in us, and they feel comfortable with us because we look like them and we're genuinely here, hopefully, to help them as well.
So I wanted to follow that up, and maybe you can help me understand this. The problem that we have, especially in my specialty, in taking care of cancer patients, is that the majority of clinical studies that establish standard of care, let's say 5,000 women were randomized to placebo versus tamoxifen. The majority, 99% of those 5,000 women are white. The other day I had a patient who walked into my office and she has breast cancer and there is a new medication, Ibrance, $400,000, every 2-year treatment. That's a very expensive medication. And I proposed it to her, and the first thing she asked me, how many black women were in that study? 0. So I would like, obviously we open clinical trials here, National Cancer Institute sponsored clinical trial, and I tell my patients, listen, I cannot give you the medication that works on someone else. I have to understand what works on you. And the most heartbreaking story that I'm going to share with you is in acute leukemia in children. We had 98% cure rate for the past decade in whites, and it was 70% in black kids. Until somebody said, let's do a study in their genome, they looked at their genome, they detected that you should give one more treatment of chemo. When you gave, instead of 4 treatments, 5, those kids had 98% survival rate. So there are some biological differences. And if our patients don't want to participate in clinical trials, we will never learn, because we learn from them. This is a two-way street.
Like I said, most of the people, like I said, most of the people that are participating in research, they are, and even the availability of these clinical trials, they're at elite institutions that minorities do not have the ability
We have it
to
here.
access.
We have it here, yes. We have a cancer program with multiple clinical trials open in breast, in lung, in genomics to understand their own tumor and what targeted medication works for them.
And the study staff looks like them too?
Yes, we have the trials here. Since I came, that was my first priority, to bring in understanding to my community.
Yeah, and I want to say yes, if maybe study staff may look like the patients and so on, but the trust, that's something that we cannot underestimate. If you have a system that for a long time has been one in which trust, you had a lot of mistrust, it's hard to just change that around overnight. And I think that it takes relationships, building relationships with the community. It takes making system changes, and within the community, within hospitals, within study areas, the coordinators, and it takes a concerted effort to do that. And so the trust is something that we cannot just kind of like put under the rug. And in addition with trust and over time with building proper relationships where you'll have more trust, another thing too is making sure that people are educated about it and going into the communities and talking about clinical trials. There are not a lot of there really isn't much education where it comes to clinical trials out there in the community. We may talk about prevention and we may talk about different things that people should be doing, but we may not talk about clinical trials, how people may have access to clinical trials and where those opportunities are. So sometimes things happen in silos, and with well-intended people, it may happen in silos that we are thinking that, okay, we are doing the best that we can, but one silo isn't communicating with the other, and I think we need to have that communication, and we need to go to the community and make sure that the education happens there.
That is an excellent point.
Additionally, there is a layer that I think we're glossing over. I think generally speaking, when someone is going through a battery of tests, there is some anxiety that's involved in it. There is a lot of crazy making in the head. It's, people start to reflect on all of the different things that they would have done, and they talk themselves into thinking that it's positive and or negative. So many times when they get the result, they're not in the space. They're physically there, but psychologically they're someplace else. And because of that, it's easier for them to say to the professional, to the expert, to the practitioner, well, you tell me what? You tell me where I should go with this, because in that moment, they're not thinking about what's before them. On the other hand, if they have had the space, time, knowledge, and everything else that comes with it to think that, okay, I'm at risk of breast cancer based on whatever has been told to me, and they were able to do some research, I think they're in a better place to have a better dialogue with the practitioner. But in most cases, they are not prepared that way, and they leave it up to the practitioner.
Dr. Tenisud?
speak to where I am at Fox Chase Cancer Center, and because our patient demographic is predominantly Caucasian, our patient navigators are predominantly Caucasian. Yeah. Exactly. And even when we move over to like Temple University Hospital, which is in an urban area, yeah, there might be one African American, but like you're saying, there's not going to be someone that you can refer to if I'm Muslim and I have to have my husband in the room with me or something like that when there's not someone there that that's culturally competent to help in those situations. And this is, I believe you said it earlier, this is something where we all have to kind of link together, the clinicians, the public health practitioners, and everybody to kind of address these issues because they're major issues that we, for the most part, don't answer.
Yes, ma'am. Go ahead.
So I want to answer like all of your questions in parts. So again, I work with Dr. Reagan, and she was discussing a leukemia study that was predominantly done with white people. So our cohort is healthy individuals in Philadelphia County. So when Dr. Reagan first got to Philadelphia, we went to like the mayor's commission for African and Caribbean immigrant like council. So we got like pretty much hit every community-based organization that outreach to these groups. And we have a list, the Caribbean, we have a list. And that's kind of like how we linked. So if they had a health fair, we were there with a table with cancer prevention health information. We collected like the data that she mentioned, the demographics, the health behaviors, everything. And they were more comfortable talking to us. And you're right, they don't want to go to the doctor. They don't, and the only thing we can do is kind of like, we nag as like a second wife. I hate to be that way, but we try to tell them. And even if I've had numerous Nigerian wives come up to me like, my husband has a problem with his prostate. What do I do? What do I do? And we give them the information, but then we talk to them too. And we have to sell them pretty much their future. Like, you don't go to the doctor. How can we get you to go to the doctor? Don't you want to see your grandson in the future? Stuff like that. Yes and no. It's hard. We went to, it was back in September, we went to like an AFRICOM. AFRICOM is a community organization that deals with the African community in Philadelphia. And we had not one person come to the table pretty much that day. And we have like PhDs that work for Blue Cross Blue Shield. Like they work with us and they will try to send them to the table. And once they hear what we're doing and they hear cancer, like you said, it's kind of like, okay, thank you, have a nice day. And they just kind of walk away from us. It's really hard, but at least we're out there and we're giving them the prevention information. It's like kind of like you have to start somewhere and then hope to evolve and bring more people in.
All right, go ahead, sir.
Question. I work for Orchard lack of diversity in the health profession. But then you run into the issue of people resistance and affirmativeness, and so worried about position and understanding the knowledge base that you need to address the need of the patient. Because I think that's one of the fundamental of issue of trust. That there's a group 11 in that project that I just mentioned that include underutilization of Medicaid, but most of it immigrants community, a Latino person and gone to our community. If trust is not built, included in the navigation process, that is systemic too. As one example, we did stuff on colon cancer in our community, prostate. It took relationship, even after you did the test, become possible. That the system that you recommend them to has the capacity to culturally, trust-wise, level of knowledge, of skill, and technology, and basically really go to it and fix the real experience for people that done. A lot of tests became find out that they need to go to the doctor, but they trust the system that it will recommend. So a lot of those tests were not tied to cultural competent quality prediction of the population needs. And with this, what our sister was saying, we have partial, the concept that the practitioner has, the practitioner culture, is more an impediment because they have a reading already of the patient. So one of the things we always do is ask the provider, within your culture, how do you understand this? How do you relate to this? And you see some differences of assumptions. So I think that both sides understand the culture of the patient, the culture in the totality, in a different way, and the person who provided the care, they're aware of the differences of that. So I think we need to know intersectionality in how we do it. I think we need to integrate what people are trying to do now, address those social factors and social determinants, and make sure that the system that we organize respond to the different needs. I'm in disagreement. In many times when we talk about patient, your description ends up stigmatizing them and making them responsible for their illness, so they don't respond. We have to find ways that in spite of that, what are the social structures, what are the interventions that can increase the responsiveness of the patient in the area of care? And that doesn't say, well, you know, they don't listen, they're bad, they're this and that. How do you get around that? I think people are trying to work at that. That will be a little more specific. What systemic and what ways institutions can change? Because system refuse to change. It's not just saying it during your policy. It's changed. We have other places with our best practice and we know what works. I think it's important to integrate several extended as well covers deeper conversation.
Thank you very much. That was very, very helpful.
I know on that note of outreach and trying to change the culture of demonizing illness, Lakeya, I know you have been involved in outreach from BHDC. Did you want to tell us your experience with outreach?
And you may use these social networking opportunities and networks to promote many different health behaviors, from the youth all the way through until the older population. And it increases interaction amongst everyone, clinicians, people who have taken part of clinical trials, as well as those who need to access information. The internet is being used for multiple outlets, and these are ways in which we can use these outlets to promote pretty much a lot of healthy behaviors. In terms of peer social and emotional aspects of it, yeah, I may have taken part in a clinical trial, and I don't know anyone who has, or I feel a certain type of way about it and I'm not comfortable discussing this with my clinician. I can go online and I can have this community where those who also went through the same process of the clinical trial that I've been in, and I can go into these networks and we can talk about it and we can share ideas, and it's a sense of a trusting community other than just speaking to my doctor. There's someone who actually went through what I went through. So today we can use social networking in many different aspects in terms of promoting healthy behaviors within our communities.
I just wanted to add that that's another form of intervention when working with diverse communities. If you have peer support of someone who's gone through the situation, it's more readily accepted when you sit with someone who is walking the same path that you're walking. So that has also been found to be an intervention that is effective when treating individuals who are diagnosed with cancer.
That is a wonderful, wonderful point. And the other thing that I want to add is the fact that patients in our community here, they don't feel empowered to talk to the doctor. So I treat very intelligent people, and a lot of them have college degrees. Believe it or not, more than 80% of people that walk into my office have college degrees. And they have a disease, and I give them chemotherapy. I give them my cell phone number. Guess how many times they call my cell phone number? 0. And I worry all the time that they're not empowered. They feel like, oh, they should not call the doctor. And it's always, for me, it's always a struggle, because, I don't want them to have fever or some complication from chemotherapy and I will not know about. So I usually try to get somebody in the family, to the daughter or somebody, to call me or to text me if there is something wrong. So I call the patient. So it's very important for us to have not only navigators, which we don't have, but also peer-to-peer, peer facilitators, because the patient will be much more comfortable in talking to their peer, and the peer can call the doctor than themselves. This is in stark difference with the patients that I saw in Long Island and North Shore LIJ, that they will call you at 3 a.m. for anything, just to talk. So it's sad, and it's worrisome when you're not called. When you ask them, call me, and there is no phone call.
I think maybe a question is, what would be some of the reasons that they are not calling? And I think it brings us right back to the piece that is culturally ingrained. I think we really need to pay attention, and I respect what the gentleman said just now about the existence of these problems being here for like a zillion years. And here we are a zillion years later talking about them. I think more research needs to be done to get us to more research in addition to what we've heard. Because Dr. Reagan, the research that your presentation was right on point in terms of talking about the differences, the sociocultural piece, the advocacy piece. All of these different pieces, and sometimes funding is involved, that we have to recognize that. That could be a shortfall, but at the same time, I think more emphasis needs to be placed on the cultural aspect of the patients when they're coming to see us. How are they understanding receiving their diagnosis, how comfortable they are? I think more work needs to be done, and to speak to what you were saying, Dr. Tenniswood, more of that. I really think that this is the beginning of something good in terms of focusing more on the cultural dynamic of the diagnosis.
One of the things that's worked with us is when we have gone out into the community is we go out into non-traditional settings, so we reach people where they are. So you'll find us in beauty salons, barbershops, faith-based organizations. But something that has worked, in addition to the education about a disease process or about treatment, it was telling people, giving them a list of questions that they can ask their doctors, and so that people feel comfortable with asking those questions. And yes, there is some cultures that you may feel that the doctor is a professional and they should be the ones telling you what to do. But I think as you educate people and you talk more about, okay, these are some of the ways that you can ask your doctors questions. In our salons and barbershops, we have role plays where the stylists do role plays as a patient and as the physician, and they play the roles so that they feel comfortable talking to their customers about diseases. They feel comfortable about empowering their customers, for the want of a better word, empowering them to talk to their doctors and empowering them to ask questions about their disease processes. So I think those communication, those conversations have to take place, and as you mentioned, the peer-to-peer piece is really important. Who are the trusted people within the community that you feel comfortable talking to? Do you have the social support? Do you have the social networks that we can tap into to make sure that those messages get out there and that people feel comfortable talking about them?
The flip side to what you're saying is that there are some doctors who do not allow patients to talk to them, to ask questions, because they set up the meeting in a way in which the patient feels so intimidated that they don't know which way to go. There's some doctors like those out there. And I know we're preaching to the choir in here, you know, those doctors are not sitting in this room right now, but there's some doctors who are guilty of that.
And so the education has to be on both sides. Yeah, there's the cultural competency, there's the health literacy that has to take place, and things have to take place on both sides.
You know, you said that and I had a quick flashback. I have a cousin who died of bladder cancer recently, and his last visit, I went to the doctor with him. And I was flabbergasted because the doctor pretty much behaved as though, what are you here for? You're wasting my time. And when I opened my mouth, he had like a dismissive first couple of sentences. And once I responded and he realized this is somebody with something in their head, he really backed off. And then we had a civil conversation. So we have to also consider that those doctors also practice.
So there is a certain etiquette of approaching cancer patients has to be taught in medical school as curriculum, because we don't teach communication skills to the doctors, and this is very sad. We just assume that they're good people and they will know how to do it. Back in my homeland, we were taught communication skills and how to break bad news and how to relate to patients. And I come from a culture that is very similar to the Caribbean culture. We're very much family oriented. We don't go to the doctors. We're like, take care of our own. So you know, it has to be, we need to have a curriculum in which we teach communication skills and culturally sensitive communication skills. Every patient should feel appreciated and valuable and precious, because every life is precious, and that's what we learn in medical school, but we don't know how to express that. I usually bring the entire family, and because it's usually like sister, brothers, cousins, in-laws, everybody's there. I think we as a group and we as community leaders, we must ensure that there are outreach activities and we get funding to pay their electrical bill, to pay their rent when they undergo cancer treatments. And this is what's done in Europe. There are civilized countries in Europe that if you have cancer, you're home 6 months with paid leave. And also somebody pays your electricity. There is somebody who comes and does personal shopping. There is some sort of that, and I can get it sometimes through the insurance. It's called personal care assistant. So I get somebody to go and do the groceries for them and help them at home, but they still need the money to pay for that. I don't have, like in Europe, you have a packet of money, you apply for the grant, and the patient is covered. We need that here. We absolutely need that here. If you look at our community need assessment, 75% of men admitted in the hospital with cancer, they die. They come in such an advanced stage that they die. This is wrong. It's like nothing else in the United States. It's like nothing else in the civilized world. We must do something to provide a safety net for those men. They're responsible. They have children at home. They're not going to abandon the child. Anybody has any comment on that?
I hear what you're saying, and I discussed it a couple of weeks ago in class. And the United States of America is a capitalistic society. We care about the almighty dollar. You go to most European countries, like she just mentioned, and you know, maternity leave can be up to 3 years, and fathers get a year. In America, what do we get? Six weeks. 6 weeks. That's how it's 6 weeks. We don't care about your health. In Europe, they get like 3 months of vacation. We're fighting to get 2 weeks.
And they don't have money to go on vacation.
And
It's
you don't have money to
absurd.
go
With 2 jobs. I have patients that have 2 jobs and live in shelter because they don't have. What kind of nonsense is? I'm, it's just for me as coming from Europe. It's like I cannot believe it. And this is New York City. This is not Boondocks, Alaska, or somewhere. It's just what happens.
And where do you fix the problem? Your question, it's not a question that many public health practitioners, many physicians, we all ask the same question, and it doesn't seem to get answered because the only thing that government as a whole, the only thing we're chasing is $1. If you get sick, in most cases, what does your boss tell you? Come on into work. Do you not even see, I don't know that much about Obamacare. I've always had health insurance, but even the resistance that we get as far as Obamacare and covering everybody with health insurance. Look at the pushback we really got in this country for that. That's like basic in Canada, in most Caribbean countries, the government pays for
All Europe. It's a
Europe.
birthright. Healthcare and education, free college is a birthright. How do you raise the next generation if mommy and daddy has to pony up the money or grant you? What is this? That should be free. Why should the very rich be like millions of fold richer than the very poor? This is wrong. It has to be somewhere in the middle.
I think, I just think we need to throttle back a little bit. I agree with the comments that I'm hearing, but the bottom line is the patient is in your office and there is a diagnosis. So whether the person is doing 2 jobs, whether the person has childcare issues and all of that, how is the expert, the practitioner, talking with this patient about the patient's particular issue? I think that is critical. We can go all around the world and talk about these different systems, but the bottom line is we have to think about giving individualized care that is culturally competent, that is at least getting the patient on a path that is reasonable to move forward with respect to care, optimum the care as it can be.
I'm a pathologist. I do see specimens from surgeons, and the usual steps that people go through as a white patient is different than I see for black patients. Because the black patients come to a surgeon, they know she's not coming back. They just do the surgery right there. They do not do a biopsy and then follow up and then surgery. So it's just, I see a totally different approach that a surgeon takes with a black patient versus white patient. And good or bad, but maybe that surgeon knows how these patients are lost to follow up, and maybe that is the best strategy at that time. I'm not going to blame the surgeon, but it's just maybe another example of a culturally different population, and they may not get the best treatment.
They have significant economical burdens. Just to get back to the previous point, in Brownsville, it's a whole zip code. It's like over 100,000 people live there. There is not one multi-specialty clinic, 0 multi-specialty clinic in the entire Brownsville zip area. This is outrageous. If you go, anywhere, downtown Manhattan, you have 40, 50 multi-specialty clinics. I mean, that's wrong. There's something wrong here. And I think that the wrong comes from the reimbursement. If you pay doctors less to take care of patients in Brownsville, you send the wrong message. And that's a message that cannot be tolerated. A life is a life.
I think that's another reason why patients don't follow up, because of the lack of accessible care in the various neighborhoods. I think it is a valid point, and I wonder if it becomes an ethical issue with what was just said, if some practitioners are deliberately treating black patients one way and white patients another way. I wonder how does the whole ethical piece play into that, if they're deliberately doing that. I would question that.
So I enrolled many patients in clinical trials over the past 10 years. I never had any resistance from blacks versus white for participation. As long as you do the informed consent process, you give them all the information, you answer their questions, there is no problem. So the only problem is trust. The patient has to feel that you care for them and that you're going to be there for them. That's all, nothing else.
I'm sorry, we have to finish, but I want to give Laura Martello the last word. I know you haven't had a chance to speak. But you participate in a very important study sponsored by NIH looking at cancer disparities in colon cancer. Just to preface what I was going to ask you, was with benefits come responsibilities. So when you ask for tissue from patients to do your research, what are the things you talk about, and what are the responsibilities of these patients that are asking all these questions about their specific population?
So we were a recent recipient of an NIH grant to study GI cancer disparities focused on colon and pancreatic cancers. And so essentially there's two pilot projects, one focused on colon, one on pancreas. And the key to this entire study is to really get at the molecular basis of the higher incidence and the worst outcomes that we see in African American patients. Now, the tissue banks that are throughout the country are, as you see with many other things, 95% filled with Caucasian tumors. And so a lot of the research that's been done, a lot of the understanding of the molecular basis of Caucasian colon cancer is out there. But what's happening with African American colon cancer, Afro-Caribbean colon cancer, that is still a big black box. It is unknown. And so we have a very great opportunity here at Downstate to increase representation of minority biospecimens to really get at the answers to these questions that have been there for years. And the statistics are there. We know that this exists, but we have not really had enough biospecimens to actually look at in order to address these questions. And so part of the issue that we face now is that we're trying to get subjects to participate, patients to participate in this type of a research study, and yet we still face resistance. And so I think a lot of what we're going to be trying to do over the next 3 years of this grant is to work with the Brooklyn Health Disparity Center, Arthur Ashe, to really get out in the community and to educate the community as to how important it is to, in our case, we're asking for a leftover piece of your tumor. So basically this piece of your tumor would be discarded and unused. And from that, leftover piece of tumor, we can actually learn quite a lot. And the more biospecimens that we have, the more confident we can be as to our conclusions. So I think all of what has been discussed today is important for me to hear, because this is how I develop my different strategies for increasing. Every patient that we attempt to consent for these research studies, we want a yes, because that's the only way that we're going to be able to answer these questions. And so understanding why we get a no each time, and seeing if we can even change that no to a yes with maybe changing up the conversation, that's going to be critical for us to really carry out the work that we're attempting to do. And this grant also has value in that one of the other components of the grant itself is cancer health disparities training. So what we're trying to do is actually increase the representation of minorities to actually stay and do research, be it with an MD degree, a graduate degree, a public health degree, and get them realizing how important it is, the research that we do, and get them more involved. Because if we have essentially community members with these degrees out in the community, they're the best ones to inform the community about the importance of this research that we're doing. And so I think if we can really continue to get the support that we initially have gotten with regard to this grant. I think, our goal next is to apply for an even larger grant to expand, essentially what we've been trying to establish initially. And, with things like this, where we essentially, I don't want a Caucasian tumor. I only want African American, Afro-Caribbean tumors. That is the focus. This is an opportunity that should not be missed because, these opportunities do not come around. As I said, the national tumor banks are 95% Caucasian. So I'm hopeful that we can really get the support that we need to really make some inroads in this study that we've started.
Thank you.
Okay,
Dr.
I
Stryker.
think Dr. Stryker is indicating that we've had
Well, I would like to thank these two doctors for facilitating this session and for the panel for being flexible in changing the way we discuss these matters. I think everything that was captured today is critically important. One of the things I did want to say, though, is that you can teach doctors communication skills. What you cannot teach is empathy.
Yeah.
And so, as we go forward, we have to think about how the people in this room who are empathic can really pick up on whether others are, and really begin to share with our population, my family included. I could tell stories about my mother and the doctor, but that we can share with others what to do, that we can provide them with the questions that they should ask, that we should tell them when they should say thank you and never come back, that all of the different things that we've shared. But I also feel we need to give a great amount of support to the doctors who are providing the care here, and that includes everybody in this room. Because to go against the grain, this morning we heard her talk about swimming upstream. We are constantly swimming upstream because we don't have enough resources. We don't have enough to really do this the way we should be able to do it. So I want to thank you, and I want to thank everyone here for participating today. We will be developing coursework and developing other things from it, and have a wonderful weekend. Okay?
Thank you all.
So this concludes our summit today.